Good morning to all of, and welcome to all our viewers out there. I am William Battle, a member of the Omega Psi Phi Fraternity Incorporated Gamma Pi chapter, where I serve on the chapter's health initiative. You know, annually in the United States, the month of November is recognized as American Diabetes Month. And at such times, many organizations are dedicated to raising awareness about diabetes. Well, each month, Gamma Pi hosts a webinar focused on a particular health topic. On today's webinar, we will be uplifting and raising awareness in our community as the Gamma Pi chapter's health initiative presents Diabetes Awareness Month, Getting Care from Your Primary Physician. I also want to note if there's anyone of our viewers, if you have any questions, please don't hesitate to place them in the chat. Thank you. So our guest today features our very own fraternity brother, Dr. Kevin Ford Sr. Dr. Kevin Ford Sr. is a native of Scotch Plains, New Jersey. Dr. Ford received his Bachelor's of Science degree in biology from Rutgers University in 1983 and a medical degree from Howard University College of Medicine in 1987. Dr. Ford completed his internship and residency in internal medicine at Howard University from 1987 to 1990. Once completing his residency, Dr. Ford took a position at the Group Health Association from 1990 to 1993 as clinical instructor in the Department of Medicine and Healthcare Science at George Washington University. After which, Dr. Ford relocated to Houston, Texas, and worked at McGregor Medical Associates from 1993 to 1994. And then he relocated back to Washington, D.C. area in 1994 to work for George Washington University Health Plan from 1994 to 1999. At that time, he also served as assistant professor in the Department of Healthcare Science and Internal Medicine at the George Washington University School of Medicine. In 1997 1999, he served as the Associate Division Director of Internal Medicine for the Suburban Health Care Center. In 1999, Dr. Ford formed a private practice internal medicine group, namely Ayers and Ford, PA, where he served as vice president from 1999 to 2007. And in 2007, he started a two-physician private practice internal medicine group called Ford Medical Associates, where he is currently serving as president. Good morning, Dr. Ford. I'm going to yield there because this could go on and on and on for eons, you know? So I'm going to stop there, but welcome to the webinar.
All right. Appreciate it for having me, Brother Battle. Appreciate it.
Thank you very kindly. So let's get this thing started. I'm a data guy, and I believe in studying to show oneself approved, right? So I looked at some of the information. I went to the American Diabetes, and I was just trying to engage myself. So here's what I want to put out there right quick. More than 37 million Americans, or 1 in 10, have diabetes. It is estimated that 20% are unaware that they have it. 95% of cases are type 2 diabetes. Mm-hmm. It is estimated that 643 million adults will have diabetes worldwide. The prevalence in the U.S. is estimated to increase to over 54.9%. And the number of people 65 and over is projected to increase to alarming numbers. So would you or would you not agree that this diabetes is very common and is at epidemic proportions?
I mean, absolutely. Diabetes is so prevalent. I think in my office, I probably see, if I see 20 patients, 12 patients will probably come in that have diabetes, right? Not necessarily, the reason they come in, but they have diabetes. Mm-hmm. And so, it's so important to make everyone aware, to get tested, to be aware so we can try to treat diabetes early on.
Okay. Yeah. So for those for our viewers that may not be familiar with what this issue is, what exactly is diabetes and how can people be treated for it?
Okay. That's a great question. So basically, diabetes is when the glucose or blood sugar increases in your bloodstream. And so the problem, what happens is that you have an organ in your body called the pancreas.
Mm.
And the function of the pancreas is to make a hormone called insulin. I think most people heard of insulin, but really may not know why, what it's used for. So what insulin does, it helps to drive the glucose or sugars into your cells to give it energy. But what happens in diabetes is the pancreas either doesn't make any insulin, and that's a certain type of diabetes called type 1 diabetics, where they don't make any insulin whatsoever, or you have the insulin, you're not making enough insulin, or the amount of insulin that you're actually making, your body is resistant to it.
Okay.
So what happens when if you don't make any insulin, then your sugars, really go up through the roof. I mean, they get very high, and that can happen very quickly. When your body's resistant to the insulin, it just doesn't drive the sugars into the cells as well, or if you're not making enough insulin. And so that's the basic premise as to why your blood sugars will elevate.
So where would you categorize type 1 and type 2?
Right. So let me just say there's different types of diabetes, right?
Okay.
You have type 1 diabetes, and that's when you don't make any insulin whatsoever. So those patients have to be treated with insulin in order to survive. Okay. The type 2 diabetics, those diabetics either they make some insulin, but they either don't make enough, or the amount of insulin that their body makes, their pancreas makes, their body it's resistant to it, meaning that you can make, say, a lot of insulin, but your body doesn't respond the way it should to the insulin.
Okay. You mentioned in your earlier statement about the high and low blood. What are some of the symptoms? Glucose. What are some of the symptoms that one should be aware of when it comes to if your blood sugar is too high, if your blood sugar is too low?
Right. So diabetes is when your blood sugar is too high, right? And so what happens is all of a sudden you start to urinate a little more frequently than normal. Your mouth may be dry. You just can't quench your thirst. Your vision sometimes become a little blurred. You start to wake up out your sleep at night, right? If you don't wake up at all of a sudden you start waking up 1-2 times a night, going to the restroom. And as the sugar increases, as your blood sugar increases, that frequency of urination increases, right? Also, you start feeling real fatigued and tired. You can feel nauseated, So those are some of the basic symptoms that happen when patients become their blood sugar gets elevated.
What's a good targeted blood sugar? What's a like a normal number?
So normal blood sugar should be between 70 and 126. Okay, that's normal for everyone. Now, if your blood sugar, so the way we diagnose diabetes, is about 4 different ways we diagnose diabetes. One, if your fasting blood sugar is above 126 on 2 occasions. Okay, that's the first way. Number 2, if you're not fasting, meaning you've eaten already and your blood sugar is over 200 and you're having symptoms with diabetes, then you can be diagnosed with diabetes. Another way is with tests called the hemoglobin A1C, right? So this particular blood test averages out how your blood sugars are doing over a 3-month period of time, right? So there's different criteria. Blood sugar less than hemoglobin A1C, less than 5.7, we say you're not diabetic, you're not pre-diabetic. If your blood sugar is between 5.7 and 6.4, I mean, hemoglobin A1C is between 5.7 and 6.4, then you're considered to be pre-diabetic.
Mhm.
If your hemoglobin A1C is 6.5 and above, that's when we diagnose you with diabetes. Now, the last test that we look at, and a lot of times we use this in women who we're trying to find out women who are pregnant for gestational diabetes. And you give the person a certain amount of glucose, 75 grams of glucose, and you retest their sugar in 2 hours. And it's called a glucose tolerance test.
Mhm.
If your sugar it's over 200 at that time, that's when we say, hey, they're diabetic. So there's different ways. The most common way nowadays pretty much is getting the test for the hemoglobin A1C.
Okay, good. So once an individual has been diagnosed, how and you touched bases a little bit on it briefly in your last answer, but once an individual is diagnosed, what are some of the ways that it can be monitored?
Okay. So it can be monitored by what we call finger sticks,
Mhm.
right? And so basically you would prick the finger, you check the sugar, and to see, how the sugar is doing, whenever you check it. Usually they're checked a lot of times before eating and 2 hours after eating to just see how the food affects their sugars. And you can do that once a day, twice a day, depending on how, if you want to look more closely at the sugars hadn't been well controlled, you may want to look at it several times a day, maybe before breakfast, lunch, dinner, and some people whose blood sugars are pretty well controlled, we may only do it once a day. It may vary just at breakfast, one time at dinner.
Mhm.
A newer way, though, is what's called a continuous glucose monitor.
Mhm.
And a continuous glucose monitor really is kind of a game changer, because you would put a sensor on your back of your arm,
Mhm.
and you can use either what's called a reader or use your smartphone just to put it up to your arm and test your blood sugar without pricking your finger. Because a lot of times patients, they don't like pricking fingers, right?
Mhm.
So, because it may be uncomfortable. But this continuous glucose monitor, you can just put it up to your arm, it'll just read it without any discomfort. And you can do that multiple times along the day. And I found that a lot of patients will be able to see what foods actually impact their blood sugars. And
Mhm.
it makes people more aware of, what I should eat and what I shouldn't eat.
Mhm. How accurate is that device, that arm device?
Well, for the most part, it's pretty accurate. I think that if you find that, hey, your sugars drop too low, or if you figure it's really high, you may want to prick your finger just to see if it correlates. But for the most part, it gives us a good idea as to what your sugars are.
You know, I remember years ago I was at work and this person, um, it just seemed like he was unconscious. Um, but we read the thing on his arm that he was diabetic, and we got him around a little bit, and he reached in his pocket and he put this piece of candy on his tongue. And I'm just wondering, is that, and we speak in terms of low blood sugar, is that something that's still taking place today? Is that still a part of, say, maybe an immediate way of getting your blood sugar up?
Yeah, absolutely. But one of the things about the continuous glucose monitor,
Mhm.
good things about that is that it has an alarm on it to let you know if your
Okay.
sugars are starting to get low before
Okay.
before you pass out, or
Okay.
if your sugars are really high, to give you some kind of awareness that, hey, your sugars are too high. You need to probably do something to try to get it down. So still, we have patients that have that hypoglycemic episode where their
Mhm.
sugars get too low. And yes, you should probably carry some type of they have glucose tablets where they give you sugar to kind of raise your blood sugar up.
Mhm.
And it's amazing when you're able to eat something or take something to try to raise your sugar, you kind of come around pretty quickly. And so, yeah, but the
You
continuous glucose monitor is a game changer because it alerts you before your sugar gets too low.
I was in church, and I think it may have been August, short sleeve weather. And I couldn't help from see like the number of people that had these devices on their arms.
Mhm.
And I was just startled. Actually, I was sitting there counting the number of people. You know what I'm saying? But I know I counted at least 10 people in the church service that had these things on their arm, which gave me some indication. Wow, this thing is really prevalent down here.
It's
Um,
very prevalent. I mean, very prevalent. We're talking about this, 29 million people, diagnosed with diabetes, and even a lot of, I think it's like 8.7 million don't even really know they have it.
Good point.
Right. So the key to that is go to your primary doctor, making sure that you're getting your physicals every year, making sure that they're checking, your blood sugar to make sure that you don't have diabetes.
Yeah,
Right.
that's interesting. And it just, again, when I look at those numbers, I am just floored at the number of people that are diabetic and the estimated numbers
Mhm.
of diabetes worldwide by 2030. It's just alarming to just see the numbers and to think about it.
Yeah. And,
Um,
and, and to your point, the amount of people that have diabetes, right? We know that's growing. Also, the people that are pre-diabetic,
yeah.
right? The amount of people that are pre-diabetic is almost 3 times the amount of people that have diabetes.
Mhm.
So, you have a chance if you're pre-diabetic to go and, try to change your diet, try to exercise, and, try to make a difference to try to change that.
Which is so ironic because there's a question on Facebook, and the question saying, I think you kind of answered it. What can I do if I'm pre-diabetic?
Right. So
Um,
the first thing that we do is making sure that you understand, what foods to eat, right? To try to make life, it's really lifestyle change. And that's what diabetes is all about because it's not something you do, for 2-3 months. It's something you have to change your lifestyle for the rest of your life
mm,
to be effective, right?
mm,
You also want to exercise, right? We recommend everybody do at least 150 minutes of exercise a week, right? 150. You can break that down into 30 minutes, 5 days a week, 50 minutes, 3 days a week, however you
mm,
want to break it down.
mm,
But you remember what I just said? That's the minimum,
mhm.
right?
Okay.
That's the minimum amount, 150 minutes a week. So, it's changing your lifestyle.
Yeah. Lifestyle change.
Yes.
That's huge. And you know, the older we get, the more that it should really sink in with us that things about our diet should change, and if possible, things should change in that regard.
And,
So,
and so what happens also is that we've grown up eating a certain way,
mhm,
right? Your
yeah,
families eating a certain way, eating, all different kind of foods
yeah,
and that aren't necessarily the healthiest, right? And it's hard to break that habit sometimes, right?
mhm,
If you've been doing that for 50 years or 30 years, whatever amount of time it is. But it's
yeah.
the mindset to try to make that change.
Man, I'm from North Carolina, and you know how we ate down there,
Yeah.
and we're on the eve of Thanksgiving. Listen, I'm preparing all of my foods to take with me because I know what to expect when I get down there, man.
Right. Right.
Yeah. So I want to venture off into something that is really it's a trend with these GLP-1s that are out there now. You see so much advertised about these GLP-1s and that kind of thing. What are your thoughts in terms of how they work and how they considered preventions or treatments?
Well, I'm gonna say this: GLP-1s are game changer.
Mm,
Okay, and so for some people that know that they're called GLP-1s are medications you've heard a lot about for weight loss, but they treat diabetes, right? They also help to lower blood pressure, lower cholesterol. They have some cardiovascular benefits, some kidney benefits. We know patients that have sleep apnea and lose weight. The sleep apnea a lot of times can improve or even go away just with the weight loss. People that have what we call fatty liver, where you have fatty deposits in liver, we always ask those patients to lose weight to try to help to prevent progression. So it's so many benefits to this GLP-1 inhibitors. So the way they actually work, the GLP-1 inhibitors, you have cells or receptors for the GLP-1s on different parts of your body, but the main focus starts in the pancreas. And what it does, it promotes increasing the amount of insulin that's produced, right? It also causes, there's something called glucagon, which helps to stimulate the liver to release more sugar in your bloodstream. Okay. So what the GLP-1s do, in the pancreas, they help increase insulin, help decrease the glucagon. And so that's what helps to lower sugars, right? Now, the side of and what it also does in your stomach, it slows down how food is emptied out of your stomach. And when the food is slowed down, it makes the patient feel full. So they want to eat less. Right? It also works in the brain to help to decrease cravings, right? So you don't feel like you want to eat as much. And so that's those are some of the ways it works. It also works, as I mentioned, as far as the heart. You have receptors for the GLP-1s in the heart, which has been shown for certain the heart and blood vessels, just like everybody's heard of Ozempic. You know what that does, it also helps reduce risks of cardiovascular disease, especially like strokes. It helps in the kidneys to improve kidney function. So there's multiple different things, and they're still finding out all the things that these GLP-1 inhibitors can actually do.
What about kids? Is it safe for children?
You know, I'm not a pediatrician. I have, I don't know exactly. I'd hate to answer that question because I haven't really looked into it in that aspect. But I would imagine it may be, but I don't want to answer anything about kids.
So here's one of the questions that we just had to come up. It says, I'm seeing more kids develop diabetes. Should parents just monitor their child's sugar intake, or are there other steps they should take to lower the child's risk?
Well, let's say this. I think eating healthy, right? Decreasing, limiting carbs, the good carbs, bad carbs. When we're talking about diet-wise for treating diabetes, we're talking about avoiding eating a lot of white rice, right? Because it's high in carbs. Brown rice is better. A lot of the white potatoes, right? High in carbs. Sweet potatoes are better. You have pastas, high in, sugar. You have more whole grain pastas, I think, are probably better, right? All the sugary drinks, sodas, fruit juices, all of those things. We're going to make sure that we're getting a lot of water in.
Yeah.
Okay. And everybody's going to eat some pies and cakes and cookies. I'm sure all of us are going to have some of that come up next week. But you have to have, it's all about moderation.
Yeah.
It's about moderation. And so also making sure our kids are exercising, getting out, not just on the computer sitting home and they're looking at the screen all day and they come, you got to get out. By growing up, you're out, you're running around all day until the street lights came on.
Hey, absolutely.
Right. So you want to make sure that your kids are very active, exercising, and that will hopefully help to perpetuate that throughout life,
Okay.
right? Because it's not just the kids, it should be us also as we become more seniors.
If an individual has an A1C of around 5.8, how do we view that? Is that borderline? Is that somewhat normal? Is that what's your take on that?
So as I mentioned, when we look at the hemoglobin A1C,
Uh-huh.
a hemoglobin A1C less than 5.7, right, up to 5.6, we're viewed as not being pre-diabetic, and you're not diabetic.
Okay.
A1C between 5.7 and 6.4, you're viewed as being pre-diabetic. Okay. And so that 5.8 A1C is considered pre-diabetes. And so, changing lifestyle, changing how
Mhm.
you're eating, watching your diet, exercising, uh, if your body mass index,
Mhm.
we look at, they have a schedule versus height and
Yeah.
weight. They look up body mass index. A quote unquote normal body mass index is 25 or less, right? Body mass index, say we have a lot of people in their 30 body mass index, 40 body mass index. If we get that down,
Yeah.
so when I talked about before insulin resistance, right? When you're type 2 diabetics that have insulin resistance, if you lose weight, get your body mass index closer to the 25, it's close, losing weight, it shows that the insulin that your body's making works better
Mhm.
and will help to control your blood sugars more.
Earlier stat I shared earlier, 95% of the diabetes out there are type 2. And what you're sharing is lifestyle and
Hmm.
modifiable behaviors
Hmm.
that we should consider as it relates of trying to avoid this diabetes situation. And these are things that we can take charge of our own individual health to make a difference.
Hmm.
Uh,
Hmm.
Lifestyle changes,
Right.
diets.
And sometimes I don't know if we can totally avoid, because that pancreas that makes the insulin, those
Mhm.
cells called beta cells, sometimes, they don't work properly, but we can modify what we're doing, right, to try to help them even more.
Mhm.
Now, I know people always say, "Hey, can I reverse diabetes?" I mean, I hear that a lot, right? Reversing diabetes. Yes, you can modify it, but you'll always have it.
Mhm.
Because if you change how you're eating, if you all of a sudden change how you're eating and your A1Cs are under 5.7, like 5.5, if you change and stop exercising, start eating the way you used to, your sugars are going to go back up, right? So you
Mhm.
haven't necessarily cured diabetes, but you've been able to modify it
Mhm.
so that you can control it with diet and exercise.
Good. That's you just answered someone's question, and so hopefully that answer satisfies question. But here's another question. So what is the relationship between diabetes and hypoglycemia?
Okay. So hypoglycemia is when your blood sugars get too low.
Hmm.
Okay. So diabetes is your blood sugars are high, right? I mean, well, normally that's when you first diagnose your sugars are high, but you can keep your sugars under good range by diet, exercise, medication if need be. So what can happen is if your sugars get too low,
Hmm.
you'll start to feel, you may feel sweaty. You
Hmm.
may feel that you're get a little lightheaded, dizzy, heart may race, and some people lose consciousness if it gets way too low. And you can actually die if your sugars get too low and you don't
Yeah.
get treatment, right?
Yeah.
So that's a dangerous thing. But as I mentioned, this continuous glucose monitor that you can put on you saw those people in church.
Hmm.
Those monitors will go off and warn you before your sugars get too low,
Hmm.
right? So that's why I'm always a big proponent of my patients getting and using continuous glucose monitors.
Here's another. It says what the question here says. What actions do you recommend if you came across a person who may be experiencing medical emergency due to diabetes and professional assistance is on the way or en route?
Well, medical emergency depends on what is going on, right? So if it's a medical emergency because their blood sugars got too low, yeah, you want to try to give them some orange juice, something that raises their sugar up,
Mhm.
right? Give them orange juice or something sweet, right? And you may notice that, hey, all of a sudden they're going to start coming back, right?
Mhm.
Because you raised their sugar enough for them to be to get it out of that hypoglycemic range.
Okay.
Now, it's different if somebody's blood sugar is very high, right? So I mentioned before, normal blood sugar is between 70 and 126,
Mhm.
you know, and if someone is not taking their medicine, or say if someone is newly diagnosed with diabetes and they're say type 1 diabetic who need insulin, right? Their sugars can shoot up right away, and it could be a very dangerous situation, what we call ketoacidosis, where the sugars could be high, they develop all these acids in their bloodstream. And you want to really, those people will really start urinating a lot, their mouth is dry, they may become a little disoriented. You got to get them help right away,
Mhm.
right? Now, if you know they're already diabetic, you just want to, I don't know if it might be a relative to know that, hey, they didn't take their insulin, if they check
Mhm.
their sugars. That's the one thing about having a monitor on. You can check the person's sugar to see how high it is,
Okay.
right?
Mhm. Yeah. Yeah. I noticed one thing about myself after, and I used to eat about 3 times a day. And it always seems like I have these sweet cravings after I eat. So I always try to substitute it with maybe I love peaches with no sugar, or apple, or some form of fruit. And sometimes the cravings can be intense. So I can always keep something in my environment so that I don't go back to those old ways of doing and thinking.
Right.
But it's a challenge to be able to. I mean, again, like you say, lifestyle change, but sometimes it's just a challenge, and people have to kind of figure out what works best for them.
Hmm.
And it's not some linear solution to it. You have to figure out what works best for you.
And
Uh,
it's not easy.
yeah,
It's not easy,
yeah,
right? We wouldn't have all the people that have all the complications from diabetes if it was easy,
yeah,
right? So, you know, and you mentioned fruits, and there are good fruits and there are
mhm,
bad fruits,
yeah,
right?
yeah,
So we know fruits that are that are good for you if you're diabetic,
mhm,
eating berries, right? Blueberries, raspberries, strawberries, those are good fruits.
mhm,
Apples, you mentioned apples, that's great. You mentioned peaches, plums, kiwi, all of those are good. They're not going to really give you those real spikes as far as your
mhm,
diabetes. Now, there are certain fruits that are going to really spike it up,
yeah,
right? So we know watermelon,
yeah.
pineapples, grapes,
Oh,
oranges, tangerines, all of those are fruits that, you're saying, hey, man, I'm just eating fruit.
yeah,
But if you check your sugar after you eat those fruits, you'll know that, hey, my sugar is very high. So, it's just being conscious. And another thing I always do too, I don't proclaim to be an expert nutritionist.
right,
I'm not. I know
right,
some of the basic things you should not eat.
right.
But all my new diabetics, I refer to a nutritionist,
Mhm,
right?
mhm,
Refer to the nutritionist because they're going to really spend a lot of time getting into your diet and how you're eating and try to give you alternatives
mhm,
that can help you to manage, your diabetes.
mhm.
So I think that's an important. Sometimes we need partners, right? Not just coming to the doc, but also the nutritionist you want to see to help you manage how you're
Mhm.
eating.
Speaking of cravings, with less cravings, would that lead to a drop in sugar levels?
Not necessarily. If you have less cravings, I mean, it just depends on what you're eating. We want you to eat your meals, your three. If you're on, medication, eat your 3 meals. But it's what you're eating. Not to say you can't eat,
Mhm, mhm,
right? But it's
mhm,
what you're eating. Now, just like you just said, you ate your apple. You might get apple and get some peanut butter or something with the
Mhm.
apple, right? And
Yeah,
that's not gonna cause
yeah,
your sugars to drop.
yeah. I can't believe it or not. I mean, you just hit the nail right on the head. And a lot of, well, I guess my advantage is because I taught health education at Bowie State for years, and so clearly I have some idea. But that doesn't necessarily mean that I'm always doing the right thing, because, like you said, it's hard, and the challenge of being able to win over or renew the thinking or renew the mind in terms of diet and eating, it can always be a challenge.
Hmm.
And so therefore, I kind of, and that's why I said earlier, you kind of have to find things that works for you. And that's why oftentimes when I'm done working out, when I eat, man, I try to keep things in the car that would prevent me from kind of going back to, here's a question that wants to go back to the GLP-1. Are they still being tested by the regulatory authorities?
Well, still a lot of studies that are being done
Mhm.
to try to see what all the benefits that they may have.
Mhm.
We know, as I mentioned, before we just think about, hey, we're treating diabetes, we're losing weight, but it's all the secondary benefits that they're having,
Mhm.
right? So yeah, they have different ongoing trials to see all the different benefits that they have, or whether they're harmful, helpful, and
Mhm.
a lot is coming out even you know future. I mean, when it started out, these GLP-1s, I think, started out almost. I mean, it's been almost what 20 years almost
Yeah.
since they've
Yeah.
been there, and they started out with a GLP-1 that you had to take twice a day,
Mhm.
right? And then they said, okay, someone else, another drug company, got it where you only had to do it once a day, and now we have them where it's once a week. And the newer
Mhm.
thing that's coming out, there is a pill that's a GLP-1 inhibitor right now. Um, that because we know some people just can't take um, the injections. They don't like
Mhm.
injections, period. And so, if you can get a pill, and there's some research being done right now for a pill to be taken and to be hopefully as effective in weight loss and all the other parameters that for cardiovascular and kidney function tests as some of the injectables that we have now. The one that we have right now, the oral medication, it doesn't give you the same cardiovascular benefits that the injection does. The weight loss, I don't think is as much as um, the once a week injections that we have.
So you take the GLP-1, you lose the weight, you get the weight off. Now you got the maintenance phase.
Hmm.
So what is the probability of having to have to stay on this stuff for some that just can't seem to kind of control it? What is the probability of having to stay on this stuff to kind of keep the weight down, and so as to avoid all those things?
Right. So it's been shown that there are patients who use it and then come off of it.
Mhm.
A lot of times they may gain some weight back. Okay. They may. But it's also about, have you made the lifestyle changes?
Mhm.
Even you can't just take this medicine and then all of a sudden, hey, I'm just taking the medicine. I haven't changed what I'm doing. I'm not exercising. I'm not eating, correctly, and then expect that, you're not going to, gain the weight back.
Mhm.
Right. So you want to make sure that I think that gives you may gain some back, but you may not gain it all back. Right. If you made these lifestyle changes. So
Yeah,
some people may need to stay on it a little bit longer. And I don't even know if we have the data to say, hey, because some people say, how long can I stay on it? Right. I mean, for patients that have diabetes, we want to tend to keep them on it for a while, right? Because we're helping to control their diabetes.
I'm going to ask this question, and I don't know if it's far out there, but I'm thinking about racial groups.
Mhm.
Which would you say, with all your expertise, and hopefully we can get to answer this, which racial groups kind of are engaged with this diabetes things more so than others?
Well, the highest is American Indian and Alaskans, right? And we are right behind them as
Mm,
African Americans, right? As far as the patients that have the highest amount of diabetes in the
mhm.
U.S. So we're just a point behind. Um, Hispanics are right behind us, and Asian Americans behind them, and then non-Hispanic whites after that. So it's very prevalent in our community. We know that diabetes runs in families,
Mhm.
right? So there's a genetic component, but
Okay.
also it's an environmental component,
Mhm.
meaning how we eat. Are we gaining, how we're eating, the foods that we eat, right? The environment that we're in, foods that we're able to buy. Sometimes it's some of the social determinants of health. It's harder to get healthier foods
Yeah.
in certain communities than others, right? So you have multiple factors that may affect,
Mhm.
how you're going to eat too.
Yeah, that's interesting. You took the question because I was actually writing down the question, social determinants of health, and you got to before I could ask the question. But so you mentioned the racial groups. So I'm kind of thinking, is it a result of because our numbers are so close? Is it a result of just similar lifestyles? You think, or
I don't know.
just
I mean, it's going to be similar lifestyles as far as the different racial groups. You're saying?
what? Well, when you mentioned American Indians, then you said we're right behind them, and you gave another group, and
Alaska. Uh-huh.
yeah. So I'm thinking, well, is it because similar lifestyles in terms of poor diets, food deserts,
Mhm.
inability to be able to kind of have access to health care or good health care and that kind of thing, you know.
Right. I think all of those can be a factor,
Mm,
right? How we're eating, right? Weight, our BMIs, the weight, right? For especially type 2 diabetics,
mhm,
that plays a major role.
mhm,
Okay. There may be some genetic component to that too. So, I don't have the answer
mhm.
to that as to, but that's just speculation,
Okay.
right? I can't say that's fact, but that's more speculation.
Yeah, this is very interesting. And I'm just floored again when I look at the numbers, how prevalent this stuff is, not just in the US, but worldwide.
Hmm.
There's a lot that speaks to this issue that we're dealing with here. And the unfortunate thing is it's just a continual lust for more if there aren't some corrective measures taking place to kind of make the changes, So what are some of the things in terms of education that you share with your clients when they come to see you, doc, and they leave and go out? And what are some of the things that you share? And then when you see them on follow-up visits, how much change do you see?
So what I share, it's always about how we're eating. I mentioned the different foods that you want to avoid, different foods, in the fruit category. We just went over that.
Mhm.
Went over, we know that white potatoes versus sweet potatoes. We went over I just mentioned that.
Okay.
So definitely talking about diet, talking about exercise, right? Talking about any other barriers that are you able to get your medicine, right? Now, sometimes that's an issue, right? Some patients aren't able to afford certain medications, so you have to kind of adjust things. Um, so those are the big things that we talk about. And then also, are you tolerating your medicines, right? Some people aren't taking their medicines on time. Some people don't or they may half the dose and not tell you. Or it's just certain things. It's just building up relationships with patients so that they'll be able to tell you what's going on so you can make an honest assessment as to things that they should do. And I always say, I'm just the coach,
Mhm.
the patient's the player, right? And we both want to win. But if you don't have a good coach, and hopefully if you don't feel I'm a good coach, then you're gonna need a new doctor,
Yeah.
right? But I gotta have a player that's willing to play,
Yeah.
right, and give 100% so that they can do well. Because if they don't do well, then what happens is you start developing complications from diabetes, and we haven't talked about that yet, right?
Yeah.
So the complications that can happen if you have diabetes, if your sugars over time stay out of control, diabetes affects what we call microvascular complications and macrovascular. Micro meaning the small blood vessels, macro meaning the little bit larger blood vessels can be affected. So the first thing is your eyes, right? The blood vessels in your eyes can be affected where they start leaking and leaking blood in the eyes. And that's what we call diabetic retinopathy. And people lose this. One of the most common reasons that people lose their vision. Okay. It doesn't have to happen. You try to control your blood sugars, right? That reduces your risk of that happening. But every single year, if you are a diabetic, you need to be seen by your ophthalmologist to get your diabetic eye screening every single year. You need to do that, right? The other thing that chronic kidney disease, right? We know diabetes, hypertension, the two most common reasons why patients have chronic kidney disease, right? But if you keep your blood sugars under good control, it decreases your risk of having that. So one of the things that we do as physicians for patients when they come to the office, we're checking not only that hemoglobin A1C, but we're checking the patient's kidney function test called GFR, glomerular filtration rate. And that's going to give us an idea as to how your kidneys are functioning. The other thing that we do is to check your urine for what's called for protein or microalbumin. And that's an early indication, if you're spilling a lot of protein in your urine, that your kidney function is being affected. Okay. So, your eyes, you need a minimum of twice a year getting your kidney function checked, depending on, whether it's normal or whether it's starting to go down. It may be a little more frequent than that twice a year. Right. The other thing we know is that diabetes can affect the nerve endings, right? So we call that diabetic neuropathy. So patients may have numbness or tingling or burning sensation in their feet, right? They get that burning sensation. It can affect diabetic neuropathy. It can also affect the stomach, where we get something called gastroparesis, where your stomach doesn't function as well, where you're not emptying food out, right? So you feel full, and you may have more acid reflux and everything behind that. But those are some of the things. And then also diabetes affects the blood vessels, right? So it's a big risk factor for people having cardiovascular disease, strokes, heart attacks, right? What's called peripheral vascular disease. And that's when the blood vessels in the leg get clogged up. The arteries in the heart get clogged. That's when you're going to have a myocardial infarction or a heart attack, or the blood vessels go into the brain. That's when you can get a stroke, right? So those are the big things of the reasons why we need to try to make sure you keep your sugars under good control.
I can't tell you, well, we just lost a good friend to diabetes, and three others have had their limbs severed as a result of diabetes, which I'm assuming is a chronic process in order to get to that degree.
Yeah.
But so what's going on in this with the system that it gets to the degree where the limbs are being cut off as a result of diabetes?
So what happens, the reason a lot of times is kind of several fold. right? I just mentioned diabetic neuropathy, where you have loss of sensation in your foot, right? On your extremities, your lower extremity, your feet. And so what happens is if you stub your toe or if you step on something uh, like a bobby pin in the house or something like that, you may not realize that that thing's inside your foot because you don't have any sensation because you're not looking at your feet, right? That's why I tell patients you need to look at your feet every day, right? Get a little mirror because it's hard to look under, on the bottom of your foot. You can put your leg across your, say your right leg across your left. Look at take a mirror, look at the bottom of the foot to see if you see any sores, right? Because if you see any sores or cuts or anything like that, that thing can ramp up very quickly and cause an infection. And once the infection starts to really move rapidly, that becomes a problem. The other thing is, I mentioned diabetes causes what we call peripheral vascular disease. That's when the blood flow to the lower extremities is decreased. Okay, so you're not getting good blood flow to the tissue. So then that can also create ulcers and different problems. So the bottom line is this: go to your doctor. Make sure you're going to your follow-ups, right? Making sure that they're looking, they're checking your feet, checking, seeing what your blood flow is in your legs. And there are different tests too, actually checking diabetes. It's called the ABI, right? Ankle brachial index. And that's when they can check to see how the blood flow is doing in your feet. Wow. Right? So that's something that you can do.
We got about maybe 5 minutes left out. I have one question here I want to pose to you. It says, it talks about members of the family being diabetic. If it basically says how much heredity in terms of members of your family being diabetic plays with chances of becoming a diabetic.
Right. You definitely have an increased risk of developing diabetes if you have first degree relative, mother, father, sister, brother who have diabetes. So you definitely have an increased risk as far as genetics, but also part of it too may be environment on how you grew up, how you're eating, and just the environmental factors too. But there's definitely a genetic component that puts you at increased risk of developing diabetes. Doesn't mean that you're definitely going to have it, but definitely it puts you at a higher risk of developing it.
You know, one last thing I want to shoot at you here. Ketoacidosis in terms of diabetes, ketoacidosis. Is that when an individual has not eaten, not taken the diabetes, and they go into diabetic shock, or what exactly we talking about here?
So usually you see ketoacidosis in type 1 diabetics, okay, right? Usually, right? And so what happens, you're building up acid in your bloodstream, which can, make you very sick, right? When you build up that acid in your bloodstream, your sugars will usually go up real high. The acid builds up. And a lot of those patients that have ketoacidosis, they're probably going to end up in the intensive care unit, right? Until they can get their sugars under better control, get that acid out of their system by giving them the insulin to control their sugars, and that will help to decrease those acids out of your bloodstream.
Wow. Hey, Doc, listen. It's all good things do. They come to an end, right?
All right.
This has been awfully informative, and thank you so much for giving and sharing your knowledge on this topic of diabetes. It is my hopes that our viewers were able to get a lot out of this information that Dr. Ford shared with us. This has really been good stuff. Hey, Doc, we might even have to do a second conversation around this diabetes, because there's so much more that can be talked about.
There's so much more. You're right. Yeah. You're right. But I think this is a great start. I think the big thing is I encourage everyone to make sure that you're visiting your doctor, because the only way you're really, going to know is to make sure that you're getting tested for diabetes. And I know, there's so many other diseases too, along with diabetes. I know Brother Battle is a big prostate cancer. I'm gonna plug that too, because that's dear to my heart also. And so I think that by going in, if you don't go to your physician, you won't know.
Yeah.
That's the thing.
Yeah, you got that right. You definitely won't know. And
You won't know.
And an unfortunate thing is just a continuing less for more. But again, Doc, thank you so much for blessing us with this conversation this morning. And to our viewers out there, thank you for making time in your schedules. We hope that you got a lot out of this. And certainly on behalf of our chapter at Gamma Pi, we thank you for joining us. And on that note, we're going to call it a day. We're going to end the program there. And once again, thanks to our viewers out there, and to you again, Dr. Ford. Thank you.
All right. And thanks for having me. I appreciate it.
All right.
Take care, bros. All
No
right.
doubt.
Real.